moving. Because we want to talk about why total knees are failing. And it's, it might be because we're putting them all in crooked. I don't know, but apparently that's not what we're doing. But let me give you a little background. So first, any disclosures I have are on the American website, the Academy, none of which are relevant to this talk. I do want to thank one of our most recent ROC fellows, Dr. Drew Shaw, who helped me prepare these slides. So acknowledgments to him. As we know now, the number of knees in the US are going up, and in India, exponentially, they're going up. And as a result of that, we also know now that the number of revisions are going up, right? So, despite the fact that we're using technology, we haven't solved all the problems that are associated with doing the surgeries that we're doing. So here's some interesting trends that, that we've seen. Most of the registries support that infection was the most common cause of early failure back in 2014, and that loosening was the most common cause of late failure. So that was the data we had about a decade ago. And this is just a whole list of things. Early on, infection, loosening, instability, stiffness, etc. You can see the late ones, all the different reasons. But infection and loosening are still the two most common things. And now most recently, it's become infection. That's both the early and the late cause of failure. So we have a whole session on infection coming up. So I'm going to just skip over infection. But it's not to say that it is the most common cause, and it is worth discussing, and we'll do that in the next session. But let's focus on loosening, because all the other joint registries around the world will have loosening as the second most common cause. All right, so let's start from Dr. Reddy's end. First of all, tell me on the panel, how many knees do you do a year?
4,000 per year.
4,000. Wow.
Yeah.
Okay, that's a big number.
I thought I did a lot, but about 500.
Yeah, fair enough. Keep going.
500.
500 to 600.
Okay.
1,000.
So we did around 2,000 primaries and 50 to 60 revisions.
Okay, so you're talking about your institution, right?
No.
Or yourself?
In our hospital.
Okay. I don't want to get into the nitty-gritty of how we're counting. How many of you have seen a case that you've done that has loosened in the last year? In the last 2 years?
Difficult to quantify, but now I'm 25 years into the practice in India.
Yeah.
So I'm seeing my own aseptic loosenings after 15 years, 12 years, 18 years follow-ups.
Fine, I accept that.
Yeah.
In the first 10 years, how common, so raise your hand if in the first 10 years you've seen an infection in your practice.
Infection.
All right, everybody, right? So that's why it's number one. In the first 10 years, how many of you have seen one of your cases loosen?
Not many.
Not many. I mean, I think
Just for one.
there's honesty and there's, yeah, but maybe one, right? Like so it's hard for me to justify, we all recognize that infection affects us all and it has no barriers to country or place or person or time. But I don't understand that loosening is a problem. And so give me one technique that you use, say in your cement technique, that you think makes your knees not loosen early.
Good bone bed preparation, like thorough lavage, and if there is a sclerotic area, we'll make multiple small holes.
Okay, so that's two. Okay, so you said thorough lavage and you made multiple holes.
Yeah.
Give me another one.
Good compression of the cement on the bone.
Okay, good. Give me another one.
I put cement both on the implant surface as well as the bone.
Excellent. Give me another one.
So keep it pressurized.
So what do you mean by that? So once the
Pushing.
the implants are on, you reduce the knee and you pressurize?
yeah.
Okay? Give me another one.
All others have been said, all other points have been already.
Yeah, I'm trying to get all of them, you know.
Cement onto a clean back of an implant, making sure that there's no fat in that interface between the implant and the cement.
Right, so both sides, implant and bone side.
Pulsavac, open the micro holes and put the cement on both implant and the bone.
Okay. Anybody put their finger in the,
Yeah.
in the keel and, right?
Yeah.
And pressurize there?
Pressurize that, yeah.
Okay. So I think we can spend all day talking about alignment, but we need to also talk about cement technique, okay? So who can give me any more techniques? Do you think the cement that you use matters?
The literature says that Palacos is better for the cementing and revision rates are less. One paper has come, but I don't know how much importance I have to give it to that. I use Palacos, I use Depu Smart Cement, and I use Striker Cement. I have not seen differences over the last 20 years.
Yeah, I think there are some evidence out there to suggest one maybe, but it's very, very soft. Most of the cements work. I think some of the cements that set very fast, if not in skilled hands, can be a problem. But yeah, I think you need to use one cement, get familiar with it, get familiar with the your team and your room. And so, are you guys all cementing all three parts at once, or both parts at once?
All at once. All at once. All at once.
Right.
All at once.
Great. So, I think the ability to have proper cement technique, tell me what's one of the problems of doing compression technique like you described, and how that can get you into trouble. So I agree with you. I do compression all the time, but when is it not a good idea to do?
In rheumatoid knees, if you extend it, sometimes you can have a fracture.
That's one problem. Exactly. What else can happen? It's a read my mind question to some degree, but I think if your knee is unbalanced and you're say very tight medially, and you do the compression, it's going to compress the medial side, but you're going to lift off on the lateral side, right? So unless you get the balance first with your trials, you shouldn't cement your implants in an unbalanced state.
Same is said about the extension, like when we try to give the extension to achieve that compression, you can have a posterior lift off also.
No, absolutely, absolutely. So it could be a posterior lift off, it could be, right? So you need compression, but it needs to be direct and balanced compression. It can't be on the posterior side if you have a tight PCL, say, or, on a varus or valgus side. And, I've said this so many times to my residents and fellows that we want to focus on alignment all the time. But the reality is it's fixation, it's fixation, it's fixation. If we fail at fixation, it doesn't matter how well aligned or how stable the knee is. So in the real world, infection is number one, loosening is number two. But what's in your practice the number one reason you have to reoperate?
Periprosthetic fractures.
Okay.
Stiffness.
Stiffness, excellent.
Instability. Instability.
Okay, that's your fault.
Occasional patella problem, if not replaced.
Patella problems if not replaced.
Periprosthetic fractures, yeah.
It is basically like rarely patella, but I'll put infection at the topmost. Like it can come at any time, but we are reoperating only for
I don't dispute infection, but like I said, we'll talk about it later. I think, if you look at these lists, right, and you talk about instability, it's the number 3 cause, right? And so, but I would argue, how often are you operating in your large practices for gross instability?
I think that instability number is kind of a catch-all. People come in, they've got some pain, they've got a bit of an effusion in their knee, you shock their knee, you're like, oh, it's a little unstable,
Right.
That's why I'm going to do the revision, and they call it instability. I'm not sure it really is.
Right, the mild laxity, yeah. But I think, I'll show you x-rays later, but like, I mean, are you guys, intra or iatrogenically cutting your MCL when you're doing a knee replacement?
Very rare, Amar.
Very rare. Yeah.
Very rare.
Come on, you're a jokester.
Yeah.
Very rare every month?
I've done twice.
Yeah, okay.
I've done
That's
twice.
an honest man.
Yeah, I've done twice, yeah.
It wasn't you, though. It was your trainee, right?
Initial days, yeah.
Right. But I mean, I think these are really, very rare things. Intraoperative fracture, very, very rare things, right? But let's talk about stiffness, all right? I think that's a very common thing.
No, Amar, let me differ that because we don't see that much stiffness vis-a-vis your population. Because when we see your papers, sometimes the manipulation rate is 10 to 20%. We hardly manipulate our knees. I don't know whether it is our squatting habits right from childhood, whether it's got extra excursions. Grade 4 arthritis, gross deformities, the flexion will be 100 degrees. So we don't have stiffness in our problem. I'm sure all my colleagues agree with that.
I mean, I think that's a great point. Do you guys feel the same way? So
Yeah, I would like to answer that because our patients are so much deformed, they are severe pain. So when we operate them, it is good for them, they do a good range of motion.
I have seen like 4 or 5 cases in last 1 year, but most of them, like they were picked up early within 6 to 8 weeks. So they responded very good to aggressive CPM and all this.
So for me, I manipulate twice or thrice a year. It's more related to the patient's pain tolerance.
Yeah.
They are very pain sensitive. They don't do the physiotherapy. Then at the end of 6 weeks, they'll end up with a manipulation.
So arthrofibrosis as a cause of failure, if we consider, it's very less here. We don't see that often.
Yeah, absolutely. I think
Unless the patient has really stiff knee to start with.
Western fibroblasts have got a different way of behavior.
I mean, but this is why we're here, because there's different problems in different countries, and we all know that your pre-op range of motion determines your post-op range of motion, and people can have different thresholds for manipulation. But I would agree with Dr. Mayman, like stiffness is a much bigger problem than I have with loosening or instability or any other, and then the development of arthrofibrosis where you can't fix the stiffness after manipulation. That's very rare, but when it happens, it's a devastating problem, right? Like
It might be something about genetics because like 2 patients I have manipulated last year, they had equally bad stiffness again after a few weeks. Like we manipulated, we put them on CPM, but they just didn't respond.
Yeah, so that's very interesting, and so we can roll over stiffness and go to other. So after that, tell me some other causes, of your failed knees. That again, not infection now, not loosening. We sort of covered that. Stiffness doesn't appear to be a problem. Instability was mentioned. What are other reasons you guys have failed knees or need for reoperation?
So mainly is a traumatic, either because of periprosthetic fracture or disruption of the patellar tendon after the trauma or fall or the some sort of injury. That's a major another cause.
So you think it's because they fell or because you avulsed their patellar tendon?
No, they fall. They fall.
So trauma. Trauma is one of the
Yes.
biggest problems. Are you seeing wound complications?
In the early operative period, yes. Diabetics, yes. We have wound complications, but most of them are okay. They do not end up the deep sepsis.
So how many, raise your hands, how many of you guys are using drains?
Subcutaneous, not intraarticular.
We stopped using drains for the last 5 years. No bad effects.
All right, I agree. So you're going to learn something this session. You don't need to use a drain. How many of you are using staples to close your skin? All right, who's doing a plastic closure? Yeah, I think the trend at our hospital now is no drains, and everyone's doing a plastic closure, and it's almost eliminated.
Amar, what do you mean by plastic closure?
Meaning a subcuticular closure that we augment with some glue material. And one of the biggest problems I've seen nowadays is that we're using these dressings that are waterproof, so that patients can shower right away. When I first started, patients weren't allowed to shower for like 2 weeks. It was crazy. So now they can shower right away, but we are seeing some allergic reactions and hypersensitivities.
Even the incidence of keloids have decreased if you're doing a good closure.
Yeah, and they don't dehiss, and so I think, you know, these are all, because if you do get a wound complication, you know, it's on the road to infection. So yeah, as I said, I don't want to discuss infection anymore, but let's go back to loosening. Who thinks the answer is going to be cementless fixation in the future?
We don't have experience with cementless, but the literature says that, because I feel that end of the day, it is the osteolysis of the cement particles which is giving the delayed aseptic closure. So which will be negated by the cementless. That's my feeling.
And the THR, the experience of cementless hips,
Yes.
we have. So we feel that it can be the future, especially, at least for the femur.
So I use cementless knees in probably 2/3 of my knees right now. And I'll be the person to sit here and say, the best thing we can say about cementless total knees is we hope they're as good as cemented total knees. We do them because they're faster and easier, right? Same reason as we do them for hips.
Yeah.
But
And that's why they took off, because they're
that's
faster and easier.
Right, but at 20 years, we haven't seen an outcome difference in terms of loosening between cemented and cementless.
Do you think cementless can be done with equal efficiency with manual jigs because of the issues of blade skiving of everything? With robotics, you have perfect cuts, so you get a very good fitting. But with manual jigs, sometimes we'll have a femur which we'll even feel at the trial that it's so good we can do it cementless. But next femur will just go in and come off. So that is because.
So, you know, I think everything in life is a process. When you put a cementless hip in, you don't have perfect contact all the time. You just want the trial to be stable, right? And then you put the implant in and it's stable and it works. The same thing happens in cementless knee. The bone cuts don't have to be perfect, but as long as it's stable when you put it on, you know, and so, you know, I think you get comfortable, and I'll answer for myself, but, you know, when I first started doing cementless knees, I did the same thing I did in hips. It was young, active males, you know, who had good bone. And now I do 94-year-old ladies that have poor bone, and it still works. So, but you don't start there. You have to work your way up there.
But in hip, we have screws for the acetabulum, just to bank upon if you think that it's not that snugly fitting.
Yeah,
That remains a challenge with this, especially with tibia.
And, you know, I've been in cases where we've cemented, you know, hips in if we didn't like how things were coming out, right? So, but as you get better at it and more experienced at it, you get to a place where you gain the confidence. Because just like in the hip, not only is cementless faster and easier, but as I was trying to get you guys to speak, you have to do good cement technique. It's not just a cemented hip is better than it's a good cemented hip, right? And good cementation of the knees. You know, and I think too many people take for granted. They put the cement on, they just, you know, they put it on, they start closing, and they're not paying attention to the fact that you need that, you know, that cement to cure before you can move on.
So Martha, that's maybe a great point, right? If you look at that list of reasons for failure in total knees, and where loosening is number 2, and you say, okay, well, we need to do something to fix loosening, and maybe cementless is how we fix loosening, maybe it's better cement technique is how we fix loosening also.
But that's why I wanted to go over those, you know, those cementing points, right? And so it solves the infection as well as the cementing. Who puts antibiotics in their cement? Oh, we had 3? 3 out of the, okay, that's good. Who uses pre-mixed antibiotics, or who uses pre-mixed, like Simplex? All right, fine. It's very expensive to use that kind of cement. I'll add it myself, but I think it's an issue, right? If you need to add antibiotics, it can affect your cement. How much antibiotics you add, all these issues are part of the cement technique process.
Amar, regarding loosening, so we are considering the conventional poly or a cross-link poly. That also depends because of the newer poly. The incidence of poly-induced wear is reduced, so the incidence of loosening is going to come down. It's not only cementing technique, the quality of the material also matters. So I think these are all from the previous data from the old poly.
I mean, I think you're absolutely right. You know, and we all have seen some companies that have had terrible polys, but by and large, the materials are getting better. We spoke yesterday about the possibility that I think in the near future, chromium and cobalt will sort of vanish in the total knee world, and we'll go to different materials. And so maybe lower things like hypersensitivity reactions and the like, they may be less over time. But
there was a recent 10-year data published with simple poly and the highly cross-linked poly. They could not find any difference as far as loosening is concerned. It's published last year.
yeah, no, I mean, but there's some very good polys out there, right? And I think Dave made the point yesterday that most of the time when we make changes to our poly, we make mistakes, right? And right now, the highly crossing poly in the hip is fantastic, and it's only getting better. But now we're adding vitamin E, and lots of companies aren't giving you the choice. Like, you just have to use it. So we'll, you know, in the hip and in the knee, we'll see if vitamin E really is an added benefit or just an extra cost that we're all bearing.
The article is about X3 poly. X3 poly.
Yeah. So someone mentioned the patellofemoral, you know, complications. So let's talk about resurfacing. Everyone resurfacing? Okay, we have two.
I not researched in the last 40,000 knees. I published a paper.
40,000 knees, so that's like 3 weeks of work?
Pardon?
3 weeks?
No.
All right.
Patellar resurfacement, as far as I am concerned, is a non-entity in Indian population.
I have never resurfaced.
Never.
Never.
Okay. So do you think the design of your trochlear groove matters if you're going to resurface or not resurface?
Yeah, because
IB2 knees done when I came to India 25 years back are still doing good, Amar. So no problems. But definitely patellar friendly implants have made it much more easy. There is no more releases now. Only thing is you got to see that the patella tracks nicely. And I prepare patella as though I'm going to put the button and leave it there.
All right, so what do you mean by patellar friendly?
The tracheal groove. So that there is no, patella cannot go out even if it wants.
So are you saying you want a constrained groove or you want an unconstrained groove?
Not constrained, but it's a contour wise from 30 to 90 to 100, the patellar tracking should be in the groove.
And then who's doing anything to their patella, like removing osteophytes or lateral fasciectomy?
Yeah, that's what
that's
patellar circumcision.
yeah, everybody does it.
All right. So let's go back. Is infection a surgical error?
Not surgical error, your bad luck. They say 80% happen in the operating theaters.
Yeah.
We stick to 3 doses of IV antibiotics as universal precautions. And some people use it beyond. And nowadays, I think you're also coming with extended antibiotic usage. You got to tell us. I don't know myself. I'm still using 3 doses. Yeah.
So is it fair to say that if you don't do a good wound closure, if you take too long to do your procedure, there are some factors that could be surgically related, especially if you're maybe a bacterial shedder as the surgeon. But are you more willing to accept that it is bad luck, or it is some?
No, it's more related to the patient.
Patient-related.
Patient's immunity.
So
Yeah. Okay. So that infection, we're going to blame on the patient.
Yeah, of course.
All right. Raise your hand if you want to blame infection on the patient.
provided we follow
Okay.
all standard
No,
practices.
infrastructure
Usually
also,
it
Amar.
is not surgical technique related.
No,
That-
not in-
we can say that.
Yeah. I mean, if you take too long, right? If it takes you 2-3 hours to do a primary knee, then
Amar, with all due respect, we get tertiary referral hospitals, we get infections. We rarely get infections from big centers. We get it from the peripheral, smaller hospitals.
I mean, I think the whole point of the information I'm presenting is that most of these cases are done in small centers
Yeah.
by low volume surgeons, right? So what I'm trying to tease out is that the complications that the world sees, whether it's in India or the US or Canada, is not necessarily the same thing that high volume centers see.
No,
right?
the big centers, they manage their own complications. You don't
Yeah.
see their
Like
cases.
that, no, Dhansekhar. No, it's not like that.
the OT disciplines, the sterilization,
Yeah,
other
that's
techniques
all.
in the smaller centers, they don't follow the norms.
Absolutely.
And it is not a dedicated theater. So many surgeries are being performed and then we are
Right,
doing
so let's go back to loosening and early loosening. Let's table late loosening for now, but which is probably more wear related and maybe cement related. But early loosening, is that a surgical problem or the patient problem?
Surgical problem.
Surgical problem.
Yeah.
Right.
I have seen my own cases within 2 years coming with a debonding. That means I put the cement late or something wrong. Just beautifully the implant came out. So that's a technical error.
So we have infection, patient problem, probably, most likely, loosening, early loosening at least, surgical problem, instability,
Surgical problem.
Surgical.
Yeah.
okay, malposition of components,
Surgeon's problem. A non-robotic surgeon's problem.
oh, okay. So let's, pain, that's number 5 on the list.
Patients.
That's weird.
It's multifactorial, so.
Yeah, no, I go. So my point is, there are clearly some diagnoses that are more likely patient-related, although it's not 100% patients, right? There are clearly some diagnoses that are most likely surgery-related, right? And honestly, I can make the argument that probably the majority of the diagnoses on that list are our fault.
Yeah.
That we control.
Agreed.
So that's why we're at these meetings, right? We're at these meetings to learn how to mitigate those factors, right? Because you even mentioned fracture and trauma, and you're kind of blaming the patient, right? But we kind of know if you're doing a hip and they get a periprosthetic fracture, is that a patient problem? Did they trip and fall, or is that a surgical problem?
If there is something like a notching of the anterior cortex, then it's a surgeon problem.
There's notching the anterior. Let's go back to the knee. There's notching in the cortex. There's your pinholes from your amazing robot that never screws up, right?
Quadriceps repair.
That happens only in the robotics.
Even
Yeah.
otherwise, it is surgeon's problem to this extent that you should spend more time counseling them.
But there is a simple rule, Amar. If the patient belongs to you, it is the patient's problem. If the patient comes from other surgeons, that is surgeon's problem.
Absolutely, absolutely. Now, yeah. So I mean, it's the point is many of these diagnoses are our fault. We need to learn how to prevent them. We need to learn how to manage them. I'm not sure the answer of never resurfacing the patella is the right answer, especially if they have severe patellofemoral disease. But I do recognize that if you don't resurface the patella well, it's the beginning of some serious problems. But we can also get things like malrotation. Okay, maybe the robot will fix that. But I just heard a guy say he used the robot and he internally rotated his femur, so I don't know what that robot was thinking. But you can get bad cuts, you can get periprosthetic fractures, but a bearing spin out, is that the patient's fault?
No,
Surgeon's
our
fault.
fault, surgeon's fault, lack of proper balancing, in the especially flexion gap. Yeah.
What about stiffness we covered? What about patellar clunk? You guys ever seen clunk?
Yep, yeah, yearly once or twice.
It is no more present now. In the older days, PS knees used to have, but nowadays it's not.
Implant related, it's more sort of,
I agree, but I would argue that I probably did more surgeries for clunk over the last 10 years than I did for loosening of my own patients, right? I did more revisions for instability or laxity because of recurrent effusions than I did for loosening, So as I was saying, there is a list that is out there, and loosening is number 2, but I think if you get good, proper cement technique, regardless of how accurate your bone cuts are, early loosening should be a very, very rare thing, right? And most of these surgical problems with proper training and technique can be avoided.